Good morning. I am Dr. Sindhuja from Cons Department from Mallareddy Institute of Dental Sciences. So today's topic of discussion is non-carious lesions of teeth. So coming to the contents, it is introduction, what and when, and lesions, attrition, abrasion, abfraction, erosion, disturbances affecting structure of teeth, discolorations, malformations, hereditary disturbances of teeth, trauma, cracked tooth syndrome, references and conclusion. So coming to the introduction, so non-carious lesions are something which are not pathologically affected, but they are caused due to physiological process. It may be repeated abrasion or repeated use of any tooth problems, tooth wearing off at a particular area. So it can be on the buccal surface or on the facial surface of the anterior or the posterior teeth. So coming to what is non-carious lesion and when was it invented. So non-carious lesions are tooth tissue loss for reasons other than caries, trauma or operative procedures. So when was non-carious lesions invented? It was invented by Miller, or coined, the term was coined during 1907 by Arthur Miller. So coming to the non-carious lesions, they are otherwise called as wasting diseases, as they mostly are affected on the facial surfaces of anterior and posterior teeth, and they occur due to either in a physical variations on the chemicals on the tooth surface or on the chemical variations of on the tooth surface, that is they are attrition, abrasion and erosion. So attrition and abrasions are mostly of physical, where erosion is due to chemical action by any liquid. So coming to the wear, that it can be classified into physiological and pathological. So pathological tooth wear is pulp exposure, loss of vitality, exposure of tertiary dentin, exposure of dentin on buccal or lingual surface, notched cervical surface, cupped incisal or occlusal surface, wear of one arch or more, inability to make contact in exclusion of mandible, restoration projecting above tooth surface, persistent sensitivity, decrease in length out of proportion to width. So these all factors contribute to the pathological tooth wear of the teeth. So coming to the predisposing factors for tooth substance losses, so these are the factors which help in the or facilitate for the tooth wearing. So these are developmental anomalies and malocclusion of or posterior tooth loss, parafunctional habits, restorative materials, diet, systemic disease, natural wear and tear. So coming to the etiology of tooth substance loss is, so it is multifactorial. So it can be attributed to stress, and again erosion and friction. So stress, or it can be due to abfraction, and that is and erosion also. These are all, they include multiple factors. So coming to these, it can be endogenous or exogenous. Endogenous is within the tooth cavity, or there is a problem in the chewing or the swallowing, or any change in the physiological process may also contribute, that is endogenous, and it can be parafunctional habits and any disturbance in the occlusion or deglutition, that is swallowing. So coming to the exogenous, that is any problems during the mastication, habits such as tobacco chewing or any other pan or any areca nut chewing, they may contribute to the wearing of the teeth, and occupation and dental appliance. So coming to the friction wear, that is, it can be from endogenous and exogenous. So that is endogenous, it contributes to parafunctional habits and deglutition, exogenous mastication, dental hygiene, habits, occupational and dental appliance. So coming to the erosion, so erosion can be attributed to endogenous, that is plaque and gingival cervicular fluid and gastric juice, and exogenous diet, occupation, and due to certain drugs or alcohols, it may contribute to the tooth wear. So there's some drugs are there like tetracyclines, which cause orangish discoloration of the tooth, and alcohol, excess of consumption of alcohol leads to the enamel loss or erosion at the enamel area, and it may lead to the tooth wear. So coming to the attrition, the first part of the non-carious lesions. So attrition is surface tooth structure loss resulting from direct frictional forces between contacting teeth. So as we can see, these are observed on the incisal surfaces of the anterior teeth. So it's a progressive frictional wear. These may be contributed from the endogenous or the exogenous factors which we have studied in our previous slides. So those are the factors are this for the attrition to be developed or to be presented, it is presented with a continuous age dependent physiologic effects and accelerated by. So attrition can predispose the following. So that is proximal surface attrition, that is proximal surface facetting, means the area between the contact areas between the two teeth may subjected to the facetting, that is a facet is formed, and the occluding surface attrition, that is occlusal wear. So any surface which has been the tooth surface losses there, it can be contributed to that particular name, that is proximal surface attrition or occlusal surface attrition. It can be attributed. So deficient masticatory capabilities of teeth. So what happens when attrition occurs? So as there is a decrease in the height of the tooth due to attrition and the incisal surface is reduced by 2 to 3 mm. So this may contribute to deficient masticatory capabilities of teeth, or biting efficiency also may be decrease. So cheek biting and cotton roll cheeks. So as we can observe, so if there is attrition in the incisal surfaces due to continuous attrition or the continuous tooth activity, and some of the factors like bruxism which contribute to the night grinding, or so what happens as there is a continuous grinding of the tooth surface, it may contribute to the cheek biting, or like the appearance is presented like cotton rolls cheeks, and there may be more amount of decay because as there is a surface loss, and there is the bacterial action can contribute to the decay, and then tooth sensitivity TMJ problems. So coming to the modes to detect attrition, that is Broca method, photographic and planimetric method, and 3D digital imagery. So how do you detect that if the particular case is a generalized attrition or is a localized attrition? So these are the modes that can be used. It's one is a Broca method and photographic and planimetric method. So the photographic evidence from the previous photographs to the follow-up photograph may contribute to and show us the evidence how the attrition has progressed. And 3D digital imagery, it shows how the three-dimensional it is affecting and what are the tooth surface which are getting affected through these. It can be detected by this method. So there is an index which was given by Dr. Richard and Brown, that is, if once we analyze and execute this as an attrition, so we can categorize them according and give them the number according to this index. So the number 0 indicates there is no wear, no tooth wear. The number 1 indicates that is a minimal wear, and 2 a noticeable flattening parallel to the occlusal plane, and 3 flattening of cusps and grooves, and 4 total loss of contour or a dentine exposure when identifiable. So tooth wear in general with erosion as one of its components, and we can rate, there is a ratings for this and there is an explanation. So that is so these are coined according to names, that is R Romeo, S Sierra and M Mike. So R shows us no visible wear or change in anatomic form, and S limited wear and change in anatomic form, and M considerable wear and change in anatomic form but no treatment, and not acceptable, these are all satisfactory. And then T Tango, considerable wear and change in anatomic form, further damage to tooth and surrounding tissue. Victor, excessive wear, extreme change in anatomical form. Aesthetics, functions, pain on chewing, damage to tooth and surrounding tissues. So coming to the tooth wear index, we can this tooth wear index is categorized from score or surface, that is, and the criteria. So number 0 indicates no loss of enamel surface characteristics and no change of contour. So coming to the 1, loss of enamel surface characteristics, and here there is minimum loss of the contour of the tooth is seen. And then number 2, loss of enamel exposing, that is lesser than 1/3 of the tooth surface, that is contributes to score number 2. Loss of enamel just exposing dentin, and the defect less than 1 millimeter deep. The loss is just 1 millimeter deep. And the third is loss of enamel exposing dentin, that is greater than 1/3 of the surface, loss of enamel and dentin but not exposing pulp, and the defect is 1 to 2 millimeters deep. So score 4 is complete loss of enamel or pulp exposure, exposure of pulp or secondary dentin, defective greater than 2 millimeters deep, and pulp or secondary dentin exposure. So coming to the treatment, how is the iteration treated? So it's a pulpally involved teeth, parafunctional activities, myofunctional, TMJ or any other symptoms in the stomatographic system, occlusal equilibration, and exposed sensitive dentinal areas and actual carious lesions. So if it is pulpally involved, then the treatment suggested is root canal treatment and further restoration with the crowns. And then if there are any parafunctional activities, we can use any night guards like that. And for myofunctional, the excess of myofunctional and TMJ activities, it can be contemplated with the use of the treatment modality of choices, myofunctional appliance. And then occlusal equilibrium can be given by setting the bite right. And then exposal sensitive dentinal areas can be used by the dentin conditioner, it can be sufficient. And acute carious lesions can be used by the restorative materials. And coming to when do you actually think that it can be restorable? So that is loss of vertical dimension, extensive loss of tooth structure when it is greater than 2 mm, and reshaping tooth structures not conducive, and decay or any other cavitating lesion, worn tooth contour, usually proximally, a tooth cracked or endodontically treated. So these all are done to regain the vertical dimension. So I'm going to the next factor, that is the abrasion. The surface loss of tooth structure resulting from direct frictional forces between the teeth and the external objects, or from frictional forces between contacting teeth components in the presence of an abrasive medium. So coming to tooth brush abrasion, the direct action of brushing strokes, the size of the abrasive, the percentage of abrasives in the dentifrice. So there is the excess of tooth brushing at a particular area causes lot of friction to generate over that particular area, and it may lead to abrasion. So for the abrasion to occur, there must be an abrasive and the abrasive action. So here the size of the abrasive particles which are used in the dentifrices or the composition of the dentifrice may also indirectly contribute. So the strokes which are given with the brush also may contribute to the toothbrush abrasion. So the type of the abrasive, the diameter of the brush bristles and the type of bristles, the force used in brushing, the type of tooth tissues being abraded. So more amount of use on a particular surface may lead to more amount of loss on that part. So there is a standard protocol to be followed for a brushing if that has been followed, we can minimize this kind of abrasion, that is toothbrush abrasion. So clinical signs and symptoms which are presented, which can be attributed to this, are linear in outline, periphery is very angular, surface extremely smooth and polished, the surrounding walls are V-shaped. Probing or stimulating elicits pain. And then other forms of abrasion are iatrogenic tooth abrasions, Picasso syndrome, certain professional habits, chewing tobacco, toothpick, interdental stimulator or other solid play control modes, pipe smoking or depression abrasions. So these are such kind of abrasions, one of the symptoms. So coming to the treatment of the abrasion, that is you need to diagnose and come to a conclusion, and then we need to find the root cause and stop the root cause. If it is coming from an iatrogenic abrasion, then the tooth remineralization approach can be taken here, and if it is a toothbrush abrasion, then the patient can be made aware of the brushing techniques, and he may be given a demonstration and made aware, and we can do it. And if it is severe, you can just go for any other treatment procedures. So then the second thing is correct or replace the iatrogenic dental work. If it is caused by the iatrogenic dental error, so then we can correct it. Either if it is wrong and during any procedures during abrasions or any restorative procedures, that can be replaced or corrected. So preventive practicing the causative habits. So once we identify the causative habit, that is the habit must be changed. And then lesions multiple shallow. If there are lesions, and then it can be sufficiently, the treatment modality can be planned with that. Involved teeth extremely sensitive and the restorative treatment. Coming to the erosion. So loss of tooth structure resulting from chemico-mechanical action in the absence of specific microorganisms. So coming to the etiology, the cause of the erosion are salivary flow. If there is a decrease in the salivary flow or increase in the salivary flow, are any variations due to any kind of chemotherapy or functionally disabled salivary glands or any kind of lesion for the salivary gland, then may the salivary flow and one of the cause for the erosion. So what happens if the salivary flow is decreased? The acid reflux may happen or regurgitation can happen, and it may cause the tooth loss at that particular area. And then ingested acid, so accidentally ingesting of acid or consumption of more amount of acidic substances, then that may lead also to the erosion on the lingual surfaces or the parietal surfaces of the maxillary anterior and mandibular anterior teeth. So excessive tensile stress at the tooth, clinical cervix, and refused acids, chelating microbial metabolic products, secreted acids and acid fumes, and mechanical. Coming to the erosion, Watson and Brooke in 2000 have given extrinsic and intrinsic strains. So the extrinsic are the environmental, diet, medication and lifestyle, and the erosion are the gastric reflex, that is sphincter incompetence, and it may happen due to increased gastric volume or increased gastric productivity. So the vomiting or psychosomatic gastrointestinal disorders and drug induced regurgitation and rumination. So sometimes there are chances due to the occupation, such as models who are their constant pressure to maintain a certain kind of personality may have this kind of psychosomatic disorders, or it may be due to any of the changes in the gastric sphincter, or this all may contribute to the intrinsic variations in the factors, and it may lead to erosion. Sometimes the drug induced gastric, because more amount of antibiotics and all for a particular prolonged period of time may change the gut bacteria, and it may lead to the drug induced vomiting and dissolve. So the next is nomenclature and classification. So according to etiology, it is classified by extrinsic and intrinsic. And extrinsic, it is environmental, diet, medication, lifestyle, and intrinsic, it may be idiopathic. So clinical severity of tooth surface, that is how can the severity can be assessed. So it is whether it is superficial or all the teeth are affected, that is generalized, or a particular 4 or the 5 teeth are affected, that is localized. So pathogenicity, it is manifesting, active or latent and inactive. So localizations, so what kind of surfaces or how many of the teeth are involved, so it can be localized to a particular surface or a particular tooth. So the surfaces involved may be palatal occlusal surface of maxillary teeth and buccal or occlusal surface of mandibular teeth. So clinical features, you can see there is no particular demarcation, and the lesion surface is kind of glazy in appearance and then does not affect occluding surfaces, and the erosion rate can also be assessed, and the thinning of the tooth structure can also be seen, and then the pulp dentinal organ and the involvement can also be assessed. Then coming to adjacent gingiva and periodontium, tooth sensitivity and carious lesions. So coming to the treatment modalities of erosion, complete analysis of diet, occlusion, habits, chronic vomiting and environmental factors. So first the gastric issues should be settled, then the treatment for the gastric part if it is then, and the systemic factors can be beyond check, and then eliminate the causes, treatment the treatment is symptomatic, and preoperative study models or photographs and restorative modalities can be assessed. So coming to the abfraction, so Gippo wedge-shaped defects in the cervical region of the tooth and are hypothesized to be the result of tensile stress concentrated in this cervical area. So coming to the etiology, mechanism of formation and the characteristics, size of lesion, typical wedge-shaped lesion, direction of lateral forces is always at or near the fulcrum. As you can see, that is the scooped out kind of lesion can be presented in an abfraction lesion. So this may be due to the direct action of the lateral forces, and this is always or near the fulcrum. So coming to the classification of the treatment, tooth surface loss may be localized or generalized, same as according to the abrasion. So we can categorize them into three classes, that is category 1, 2 and 3. So category 1, appearance should be satisfactory, and appearance is not satisfactory in category number 2. No increase in occlusal height is required, and the appearance not satisfactory, and increase in, for category 3, appearance not satisfactory and increase in occlusal height required. Sufficient space present and insufficient space is present. Coming to the indications for treatment, associated pathology, sensitivity, loss of occlusal stability and aesthetics. Principles of treatment: first of all, eliminate the causative factor, and then denture support, desensitizing agents, localized area or large area, you have to go according to the effect of that. Occlusal functions problem, extensive cases, young or old, multiple crown and full mouth rehabilitation, crown lengthening, intrusion or over eruption, and then increasing the vertical dimension. So category 1 is counseling, restoration of edentulous space, control of habits, bruxism, elimination of occlusal interference, and routine restorative procedures. So bruxism is nothing but the continuous grinding of the teeth without the it's done involuntary without the patient's approval. And category 2, same as above, counseling, restoration and monitoring. And then category 3, increase in occlusal vertical dimension, space obtained by 3 ways, and the types of restorations which can be given for the eroded tooth surface are metal ceramic or gold, full coverage posterior restoration, and short crown height, occlusal buildup and anterior teeth. So disturbances affecting structures of teeth are stage 1, secretory stage, enamel matrix formation, initial mineralization, enamel maturation, and then defects are quantitative, qualitative and maturation defects. So the lesions, so sometimes when there is complete developmental disturbances or there are lesions, then the treatment modality has to be checked in a full mouth rehabilitation. So the contributing kind of lesions are environmental enamel hypoplasia, localized non-hereditary enamel hypoplasia, localized non-hereditary hypocalcification, localized non-hereditary dentin hypoplasia, localized non-hereditary dentin hypocalcification. Enamel hypoplasia, incomplete or defective formation of the organic enamel matrix of teeth, hereditary and environmental. So localized non-hereditary enamel hypoplasia, so the causes of it are trauma, nutritional deficiency, ingestion of chemicals, and congenital syphilis, hypocalcemia, birth injury, prematurity, RH, hemolytic diseases, local infection or trauma, exanthematous disease, idiopathic causes, and then it may be presented like this in a clinical features, in a clinical photograph. The treatment defects are minimum size, and defect is occluding or contacting area. The lesions are discolored, lesion is completely disfiguring, no sufficient amount of enamel. So we can see here localized non-hereditary enamel hypocalcification, and then the localized non-hereditary dental hypoplasia and hypocalcification can be seen. And coming to the discolorations, any alteration or change in the color of the teeth either due to surface stains or deposits or factors which could have created changes in one or more tissues during the development. So stains can be of intrinsic or extrinsic in nature. So coming to the intrinsic and extrinsic stains, so these are the causes, that is intrinsic amelogenesis imperfecta, dentinogenesis imperfecta, dental fluorosis, erythropoietic porphyria, hypobilirubinemia, localized red cell breakdown, medication, bacterial stains, tobacco, food and beverages, gingival hemorrhage, restorative material and medication. So the intrinsic factors are of systemic causes, and the extrinsic are mostly which are taken by the extrinsic factors or the So coming to the extrinsic discoloration, surface staining, calculus or any other surface deposits. So coming to the clinical features, chronomogenic bacteria, tobacco products, foods, dental restorative material, medications, sulfur, silver nitrate or manganese, copper or nickel, cadmium, stannous fluoride and chlorhexidine. So coming to the intrinsic discolorations, change in one or more of two tissues, clinical features, enamel, hypoplasia and hypocalcification. And then dentin, non-vitality, pulp root canal system, that is pulp necrosis, and it has to go for a root canal system. And there is internal resorption. So these are the clinical photographs of the presented conditions, that is developmental disturbances, congenital erythropoietic porphyria, and then biliary atresia, erythroblastosis fetalis, and medications. These are caused due to drugs and medications. And congenital hypothyroidism, significant internal hemorrhage, neonatal hepatitis also. Coming to the treatment part of the developmental disturbances, first start with your proper scaling and polishing, and then intrinsic discoloration. So whether it can be treated by the use of bleaching or any bleaching agents, and then intrinsic discoloration due to discoloring changes in the pulp root canal, and non-vital bleaching, laminated veneer or porcelain fused metal or cast ceramic veneering, and then internal resorption and internal hemorrhage. Coming to the malformations, microform or macroform, and then treatment is properly aligned, malaligned, insufficient quality enamel. And amelogenesis imperfecta is a heterogeneous group of hereditary disorders of enamel formation affecting both deciduous and the permanent dentition. So coming to the types, these are hypoplastic, hypocalcification and hypomaturation type. So hypoplastic type are enamel thickness far below normal. As you can see, the mottling of enamel region at present at the incisal edges, and then open contact, small teeth with shorter roots, very limited pulp chambers and root canal dimensions, delay in eruption. So sometimes the enamel is glassy. There may be some discoloration, usually yellow. The enamel could look wrinkled, all signs of severe occlusal wear. And coming to hypocalcification, it may be presented as a chalky in appearance in early stages, and enamel chips away easily. The enamel can be very soft in consistency, or it can be cheesy in nature. Although teeth will have normal forms when they erupt, they have dull surfaces readily stainable by ages. The stains become darker with time. The enamel is worn away very easily in life with all signs and symptoms. This is a clinical photograph of the hypomaturation type, and presenting the clinical features affects both the deciduous and the permanent teeth. So there is a sexual predilection, and the color of the teeth chalky white, yellow or even dark brown. Contact points mostly open. Sometimes the tooth is completely devoid of enamel. Enamel may have a cheesy consistency. On rare occasions, the enamel may look almost normal except the presence of few grooves and wrinkles on its surface. The third photograph depicts the clinical features and does not increase the susceptibility of teeth to dental caries. The mildest form of hypomaturation is snow-capped teeth. So coming to the radiographic appearance of the hypoplastic type, you can see how it is projected in the radiograph. And then hypocalcific type, the treatment is early diagnosis. Only two modalities can be used in most cases: selective odontotomy and aesthetically reshaping the teeth. Full veneering also can be considered. So coming to the dentinogenesis imperfecta, it is the inherited disorder of dentin formation, which affects the deciduous as well as the permanent dentition, and it usually exhibits an autosomal dominant mode of transmission. So it is of three types: dentinogenesis imperfecta, which occurs in patients afflicted with osteogenesis imperfecta, that is when they have bone developmental defect also, it may be presented in that way. And type 2, it is not associated with osteogenesis imperfecta. And the third one is the type 3. It is a rare condition, that is brandy wine type, is inherited as an autosomal dominant trait from the parents. And the type 1, we can see the clinical features, that is inherited as an autosomal dominant trait. It involves the deciduous tooth more. Teeth have an opalescent color. Patients exhibit osteogenesis imperfecta. And dentinogenesis imperfecta, which is not associated with osteogenesis imperfecta. Hereditary opalescent dentin, most common type, inherited as an autosomal dominant trait, involves deciduous and permanent teeth with equal frequency, and the color may vary from grey brown, yellow brown to violet. Most of them exhibit a translucent translucent hue. The enamel, although intact, is easily chipped because of the defective dentino-enamel junction. So as we can see, the crowns are over-contoured, the roots are short and slender. These are signs and symptoms of extensive attrition. The dentin is devoid of tubules, contains a lot of interglobular formation in the dentin, and the decay process is initiated when it spreads laterally. And then root canal and pulp chamber space is obliterated. Dentin hardness and resilience is almost half that of normal dentin. Coming to the third type, that is inherited as an autosomal dominant trait, and then it is commonly seen in racial isolate area in the state of Maryland. It's commonly seen in those region, and it affects both the dentitions. It is the same as type 1 and type 2 variants. However, it often exhibits multiple pulp exposures and periapical lesions in deciduous teeth. Coming to the radiographic features, we can see a bulb shape or a bell-shaped crowns, and then the roots of the teeth are thin and there is a spiky in nature, and depending on the age, varying degrees of obliteration of coronal as well as the radicular pulp chamber is seen. The cementum periodontal ligament and the alveolar bone radiographically appears normal. Type 3 similar to those of type 1 and type 2, and these may be presented as shell teeth also. Coming to the treatment modality of dentinogenesis imperfecta, that is same as the amelogenesis imperfecta. It is early diagnosis. Two possible treatment modalities: selective odontotomy and permanent full veneering. Metal and ceramic crowns are given and not suitable candidates for playing the role of abutments. So coming to the trauma, it is Ellie's classification: class 1, 2, 3, 4, 5, 6 and 7 and 8. So class 1 is simple fracture of tooth crown involving the little or no dentin, extensive fracture of tooth crown involving considerable dentin but no pulp, and then 3, extensive fracture of the crown involving considerable dentin and exposing the pulp. 4, it's a non-vital traumatized tooth with or without loss of crown structure, and 5, it's a result of trauma, and the 6, it is the fracture of the tooth root with or without the loss of crown structure, and 7 is the displacement without fracture of the crown or root, and 8, fracture of crown en masse, that is complete crown fracture, and the 9 is cracked tooth, and 10 is cyclic incomplete dislocation of the tooth. So we can just see the classification of fractured teeth, which was given by WHO classification 1978, and that is accordingly enamel fracture, crown fracture involving enamel and dentin, crown fracture involving pulp, and root fracture. So then again it is crown root fracture, luxation, intrusion or extrusion, avulsion and other injuries. As you can see, it's a pictorially, it can be depicted here. Coming to the treatment, accurate and detailed diagnostic data, tooth vitality, incomplete tooth development or early stages of passive tooth eruption. So it can be seen, the classes can be seen here: class 1, 2, 3, 4, 5, 6 and 7 and 8. So coming to the cracked tooth syndrome, that is a class 9. It involves class 1 involving enamel, 2 involving enamel dentin without pulp, 3 involving pulp and root fracture, etiology morphological, masticatory accidents, habit, systemic causes, cyclic thermal stress, iatrogenic thermal trauma from occlusion and external trauma. So these are the diagnostic methods. One is the visible crack, radiographic diagnosis, bite on the hard objects, extensive restoration removed, crack stained, fiber optic transillumination, operating microscope, tooth sloth crack detector, probing of sulcus, history of onset, digital manipulation, wedging along margin of restoration, bright mouth light in the dark room, cold application and electric pulp texture, analgesic ineffective in nature, tender on percussion and periapical involvement. Coming to the immediate treatment part, that is immediate therapy is splinting and stabilizing the tooth and relieving of occlusion. Root canal treatment if indicated if the trauma is severe and the pain is unbearable. Coronal restoration is removed, periodontal defect corrected. Permanent restoration, reinforcing, protecting cast and cast based restoration and foundation can be given. These are my following references. In conclusion, thank you, Anand.